Thank you, Geraldine, and good afternoon to everybody. I see we've got quite a good attendance. Welcome to this, which is our first Tuesday lunchtime learning portfolio meeting for 2024. And it gives me great pleasure to welcome Dr. CM Lodder. She is a GP with special interest in allergic diseases. She has a lifelong passion to understand allergic conditions and make life a bit easier for our allergy and asthma afflicted patients. Corley started her academic journey in 2003 when she received the diploma in allergology at the SA College of Medicine. She has been a member of the SA Allergic Rhinitis Working Group since 2006 and is therefore involved in the Allergic Rhinitis Treatment Guideline development, the last review of which was published quite recently in November 2023 in the SA Family Practice. In 2007, Corley was appointed as a part-time researcher in the Department of Immunology at the University of Pretoria. The results of her research there was presented at congresses both locally and internationally and resulted in 4 publications in international journals. In 2011, Corley was awarded a PhD, and the title of her thesis was The Investigation of the Neutrophil-Directed Anti-Inflammatory Properties of Montelukast. She practiced in Boksburg on the East Rand for 24 years as a GP and ran an allergy clinic in the practice there. In 2019, she relocated to George, again practicing as a GP and seeing allergic patients. In 2021, she opened a dedicated allergy and asthma clinic in George, focusing on allergology and asthma and also immune deficiencies. Corley is actively involved in lecturing at CME events for GPs and pharmacists and doing webinars and face-to-face talks, as well as still writing scientific articles. Thank you very much, Corley, and we look forward to hearing everything about asthma. Thank you. Bye.
Thank you, Kathy, for that kind introduction, and thank you for asking me to do this talk. I am always thrilled if I can get an opportunity to do this, and thank you also for the sponsors of Cipla that made this opportunity possible. I'm busy reading a book from by Professor Mpedi on leadership and using African sayings and proverbs in explaining that. And one of the Tanzanian sayings goes like this: if you are filled with pride, then you will have no room for wisdom. And I thought that is so true about CME opportunities, because if we think we have it all and are too proud to admit that we need a learning opportunity, we lose out on getting some wise thoughts on what is going on in the medical field and improving our knowledge, hopefully on the way to become wise people. So let's look at an overview of asthma and asthma treatment, and obviously I will have an allergy hat on every now and then. So the definition of asthma is, it is a heterogeneous disease, always chronic inflammation, and there's a history of symptoms including wheezing and shortness of breath, but that tight chest, coughing, that varies over time and in intensity. And because it varies in time and in intensity, obviously it will cause variable airway inflammation. And you will see throughout this lecture that is part of what makes it difficult in convincing a patient that this is a disease that has got chronicity and that needs to be treated on a regular basis. Sometimes it helps if you show them how it looks under the microscope, because if you look at this slide, on the normal slide, You can see the architecture is wonderful. The basal membrane is intact. The cilia are there. Everything is absolutely perfect. And the immune response and the functionality of that person's lung is perfect. An asthmatic doesn't have that all the time, and most of the time not, to a variable degree. Again, that word of variability. So if you look at this and you show this to the patient, I think often they would understand that this doesn't look healthy and this needs help. So how do we make the diagnosis of asthma? It's a pattern of respiratory symptoms, as we just said: wheezing, shortness of breath, cough, and chest tightness. More than one of those symptoms. Isolated cough in adults, seldom due to asthma. If we do talk about the cough variant asthma in children, we must look at the pattern of the cough. That cough comes with exercise, with exertion, with the child that laughs, emotional expression, and then start coughing without having an infection. There's no sign of an upper respiratory tract infection causing this cough. Often with early morning hours and during the night. And then again, variable over time and intensity. And again, the word various and variable, various triggers. So what is making my asthma worse is not necessarily a cause of causing asthmatic symptoms or airway obstruction or airway flow limitation in the next patient. Viral infections, the common cold, the rhinovirus, of which there are 300 different serotypes, still the most common cause for acute exacerbation in adult asthma, and there are more and more data coming through stating the same for children. Exercise, laughing, emotions, as I already mentioned, and then allergen exposure. We cannot forget about the United Airways. So we have to remember that a huge percentage of our asthmatics will have exacerbation on allergen exposure, and therefore it is also necessary that we identify that specific allergens in this specific phenotype, which we will address in a short while, and then give guidance and advice on that. If you have got a patient that has got allergic asthma or chronic inflammation, chronic rhinitis, chronic asthma, irritants and pollutants are going to cause more symptoms in that specific patient's airways in comparison to someone that do not have any asthma or inflammation. Change in weather. That is so obvious since I've moved from the Highveld of South Africa, Gauteng, to the Western Cape and living at the coast. That sudden change and not having the same season during the same day actually impairs a lot of life quality in a lot of our asthmatic patients. And on the Highveld, everybody that is living there would know that thunderstorms can be a trigger in a phenomenon that we call thunderstorm-induced asthma. So that is the pattern that we see in diagnosis of asthma. But then we also want something that is a little bit more measurable. So it's not like a blood test that we can say that is the cutoff level, that is what we are going to do, or we are going to do a blood pressure reading and do a 24-hour BP monitoring. We can do spirometry. It is a difficult test. It is dependent on the technician and also on the patient's effort on the day, especially if it is during acute exacerbation. But it is the gold standard of diagnosing asthma, showing a reversibility in FEV1 more than 12% or 200 mils. But not every practice in South Africa has got spirometry available. We can use a peak flow meter. It's absolutely underutilized. in initial diagnosing of asthma, but also in looking at control, and especially those patients that have often deteriorating of the airflow early morning hours, to actually do the peak flow for consecutive mornings and evenings and see when that peak flow is falling, and that can actually help them to control their asthma and the inflammation better. But we can also make the diagnosis of asthma on that variability of the airflow, and we can confirm the diagnosis of asthma, taking in consideration the variability of the symptoms and the history that we have spoken about. I'm sure everybody has seen the flow volume loop before. So we do a flow volume loop, and then that is a normal airflow. This is asthma before we give the bronchodilator, and then we wait 12 minutes and we do the reversibility test, and then we can see there is the improvement in the airflow in FEV1. That will be round about there. It has to be then at least 12% and 200 ml or above. So now we've made the diagnosis of asthma. We confirmed that this is the specific patient that we see, that it does look like this patient has got asthma. So we also then, if we look at the treatment guidelines, we have to then grade the severity. But this is a spectrum of disease with a fine line between the categories. And this was a wonderful article that I read in the past 2 weeks. It was Spirology from Australia, published just now from C. Jenkins, talking about this group of mild to moderate asthmatics going from the one to the other, and how difficult it is to actually say which one it is. Because if we look at step 1, the diversity is massive, because it has to be less than, still less than twice a month. So twice a month, and then if we go to the next step, it's more than twice a month, but not daily. So if I have got asthma 4 times this month, and the next patient had it 25 times, had symptoms of acute asthma, they still both in step 2. And then if I've got symptoms 30 days of a month, and there's nighttime awakening, now I'm step 3. And then going from that, fully controlled, now we lose lung function, and now we are in step 4 and 5. So there's this whole idea of, do we really have to do grading of that? We do have the stepwise approach in the treatment, that's all good. But making the diagnosis and then rather do risk assessment, because mild asthma less than twice a month without any anti-inflammatory treatment is worse off than a moderate asthmatic having anti-inflammatory treatment every day, or at least on a very regular basis with every time they have got symptoms. 90% of the patients in primary care, at primary care physician, clinic, hospital, going to the pharmacy, would be in this mild to moderate group, but the diversity is huge. And patients do not seek help if they feel well. And on the other hand, they misjudge their own asthma symptoms. Because you must also remember that with this whole thing of variability, these people that we call asthmatics have got this tendency of airflow limitation, and they get used to it. They are used to being a little bit tight. I'm sure that a whole lot of you have got patients that if you do tell a joke during the consultation, and they've just told you that they're all good and their asthma is well controlled, and they start laughing, that they start coughing or wheezing. If a patient has got 1 exacerbation per year, that patient is in a risk group. that patient is also in a risk group to exacerbate again, because these are the patients that misjudge their own asthma symptoms. A risk factor is the high usage of your short-acting beta agonist, your bronchodilator, even if you do use an inhaled corticosteroid. If you need more than 2 canisters, which already is 8 puffs per week, so that's the cut-off limit for mild asthma. If you need more than that, you're not a mild asthmatic anymore. Even if you use, according to the new GINA guidelines, every time you have got an exacerbation, you do use your inhaled corticosteroid with your bronchodilator. It's not good enough, because the usage of the need to use a bronchodilator more than that in a month on a regular basis put that patient in a risk group to develop grade 3 and 4 and 5 asthma. Inappropriate use of short-acting beta agonists in the first year of diagnosis. This is very interesting, because up to a few years ago, our guidelines stated that in that initial phase of less than twice a month, we're okay to only use the short-acting beta agonist. Your Ventis, your Ventolin, your Astavent, that was the go-to drugs, and that was okay. But now we know that we are leaving that patient with chronic inflammation, which is detrimental. We know that uncontrolled inflammation causes destruction of tissue and organs. And this we can see now. In that initial phase and at any spectrum, if we do a full blood count and we have got a peripheral eosinophil count that is elevated, that puts a patient in a risk category for more severe asthma. Smoking. If that smoking leads to chronic obstructive airway disease, obviously, but smoking per se before they get there, because unfortunately the first 10 or 20 cigarettes that a patient smokes does not give them COPD. That comes with time. But they're already now developing, they've got asthma and they're smoking, so in the end they are going to sit with COPD and asthma. Obesity, a risk factor. Atopy, that patient that has got atopic dermatitis, eczema, and allergic rhinitis from an atopic family, they are at risk of more severe asthma. Also, an article that I'm busy reading is on the risk of severe atopic dermatitis in the prediction of more hospitalization in asthmatics that has got both these conditions. Chronic rhinitis, doesn't matter, but chronic allergic rhinitis, chronic rhinitis, we cannot treat asthma starting under the chin. We do have to start at the nose. That is the part of the lung that we can see according to Professor Guy Richards. And then if we have got a patient that already have got lung function that is not up to standard and already impaired, that patient is at risk, and we have to look after that patient very carefully and intense. If we look at randomized controlled trials, a lot of these patients that I've just discussed, being in a high-risk group, but the patients that we see in primary care, because they are out there, and that is a huge percentage of the asthmatics, up to 80% of asthmatics will fall in this group of smokers above 60, recently experienced an exacerbation, so difficult to control asthma. Poor inhaler technique, because if you cannot use the inhaler that are being studied, you can't be part of the group, but nobody addresses that. Recent airway infection. Rhinovirus is the most common cause for acute exacerbation, so that patient will be excluded from the randomized control trials, and often even allergic rhinitis patients would be excluded from randomized control trials. So the data that we have on trials are not the population that necessarily are being treated by us. And this is where the publications on real life data is also very important. Variable causes of asthma, the different phenotypes: allergic asthma, non-allergic, adult onset, small airway asthma, asthma with remodeling. Not all patients go on having remodeling, and more fixed obstruction in their airways are not variable and reversible like we see. And we cannot predict. So we have to look after our asthmatics well all the time. Your asthma with obesity, again, a difficult to control that group. And let's look at some of them in a little bit more detail. Your allergic asthmatic is that patient that most of the time will have asthma since childhood. They will have either a family or a personal history of atopy, atopic dermatitis, allergic rhinitis, food or drug allergies. So the Th2 inflammatory response are upregulated. And most of them will have eosinophilic inflammation, but not all of them will have elevated eosinophils on a peripheral blood sample. So remember that this is two different things. If you do a bronchial alveolar lavage, it will be eosinophil inflammation in the airway. But if we see elevated eosinophils on a peripheral blood sample, on a full blood count, that patient is in a high risk group. Your allergic asthmatic will respond well to, most of the time, inhaled corticosteroids, but also be cognizant, and I have to just again put on my allergy hat a little bit and just caution, in this group that has got atopic dermatitis and allergic rhinitis and asthma, we have to be very careful on the total amount of steroids that we treat these patients with. Even more important, that we have to treat them well so that we do not have exacerbation of either of these allergic conditions, so that we have to revert back to systemic steroids, which we know over time is detrimental. And like the short-acting beta agonist, even a little bit more than that cut-off level is detrimental. Systemic steroids have got a lot of side effects, and the ripple effect and the price the patients pay are really high. Your non-allergic asthmatic is that late onset, usually not a history of atopy. The inflammatory cells there, often eosinophils, but also often neutrophils. And we know that neutrophilic inflammation, that we also studied when I did my research, neutrophilic asthma, inflammation in asthmatics put them in a high-risk group. Your difficult to control asthma, your more severe, your fatal asthmatic group. And they are less responsive to steroid treatment. So we up and up and up the dosage of the inhaled corticosteroids and even give them systemic steroids, but they do not respond well. And these are the patients that with modern medicine would also do well on the biologicals. And then a fascinating group of patients are the patients with small airway asthma. If we think about children, they have got small airways. So it makes sense that when we treat children that we have to think about the molecule size that if we treat a patient. But it can be an adult with a normal build that has got small airways. I always do the comparison. My sister and I are the same height, and we have got similar traits. But she has got a normal bone structure, normal, just being jealous of her, because I really have got very small feet. And it's difficult to find the high fashion shoes if you have got small feet like mine. So there's no reason why did my feet didn't grow the same way as the rest of the bone structure. We're the same height, but I have got small feet. So you can have a normal patient that has got small airways, and we have to take that in consideration. If they are not responsive to the treatment, having nocturnal asthma, again, these patients falling in that group of severe asthma, fatal asthma, because the inflammation isn't being treated because it doesn't get to the target. And I will touch on that when we get to treatment again. Obesity is a chronic inflammatory condition per se. Those patients, we saw that in COVID, their inflammatory mediators, the cytokines, were already upregulated. And then when they had COVID on board as well, it was really detrimental for them. They have got little eosinophilic inflammation. And this is also a group, like your atopic group, that we have to be very, very diligent in gaining control, because we do not want to give them systemic steroids because of insulin resistance and the need, the price that they will pay in not controlling their diabetes well, because of the steroids on board. If they're already diabetic and if they are only insulin resistance, we might even push them over to become diabetics. So what would be the goals in treatment of asthma? For the patient, they just want symptom control. They just want to have a normal life. And we agree with them, because that is one of my passions in life. My asthmatic patient has to be able to have an active, normal life. No child should sit on the pavilion saying that I can't run with my friends because I've got asthma. And no asthmatic should be sleep deprived because of acute exacerbation during the nights. We need to have as a goal to have no exacerbations, because that also is lung invalids. I can't go to work because I can't breathe. I can't go out because I cannot breathe, or I am too embarrassed that if I start laughing that I'm going to need my inhaler, and then needing hospitalization. We have to aim at reducing disease progression and maintain good lung function and good lung growth. Some people, the lungs did not grow because maybe, just as chronic disease would be having failure to thrive in growth length in a child, we can have short lungs because those lungs were sick and poorly controlled for a long time. We have to take in consideration the risk of medication. I've said that now more than once, but we also need to keep in mind the risk of not treatment. That patient that comes to you and say, yes, but it is a steroid, it's an inhaled steroid, it's still a steroid. The risk of not treatment, not controlling that inflammation, that is just too high to calculate and just not acceptable. And we have to explain, because patients do not know that. And as again we saw with COVID, the social media likes to hamper on the negative things and not the positive things of treatments, and the negative part of not treating asthma with the anti-inflammatory. So how do we get to these goals? We confirm the diagnosis. Don't miss the diagnosis and not treat that patient with an anti-inflammatory. Do the risk assessment. And then with shared decision making, involve the patient. Decide on a treatment plan, always including an anti-inflammatory. Asthma is inflammation. You cannot treat it with a short-acting beta agonist on its own. It has to, your treatment plan has to have an anti-inflammatory. And then reassess control regularly. Don't leave it up to the patient to come back and to talk to you if they're symptomatic or not well controlled. Give them guidelines, bring them back, do spirometry, do peak flow, do an asthma control test. It's a questionnaire. It is brilliant. They can do it while they sit in the waiting room, looking at the symptoms that would cause nighttime awakening. How many times per week did you have, or in the previous month, did you need to your rescue medication, your short-acting beta agonist, and do that risk assessment. And then step up and down the medication according to the current picture and history of the patient sitting in front of you. taking in consideration was there an exacerbation or not, and the comorbidities, obesity, diabetes, allergic disease, and give them a treatment plan. Give them a treatment plan so that they can follow that and they can know what they actually are supposed to do. And then we have to look at the treatable traits as well. What is that? That is other things, non-medical education. Teach them the device technique. And we have to refresh that for ourselves. There are platforms out there that show how it works. Cipla has got, for instance, on their website, wonderful videos on showing the device techniques on all devices. Your Allergy Foundation of South Africa, there are other websites. Go there and do that. Educate them about the risk of the short-acting beta agonist because they do not understand it, because it makes them feel better. Ask about smoking, and if they do smoke, motivate them and keep on motivating them to stop smoking. Treat the allergic rhinitis all the time. I had a patient in my office yesterday with poorly controlled allergic rhinitis, and using her asthma inhaler, a controller treatment every day, because she told me that. But then the mom tells me, but even though she is doing that, she is not well controlled because she still wheezes and she still coughs when she exercises. It's a young adult, which is very active. But she admits that she stopped using her intranasal corticosteroid 3 months ago because she feels she doesn't need it. Avoidance on allergens and pollutants, but then we need to test for which allergens it is. We can't just blandly tell them to go and avoid, and give them education on diet, because we don't want obese asthmatics. So if we do then come to treatments, with what and for how long? The molecule and the schedule. So the schedule, frequency of symptoms. That whole story of step 1, is it step 1, is it step 2? Where are we? Variable. I might be step 1 this month, step 3 next month. We don't know because it varies. Severity of the symptoms, gain control with whatever it takes, because you can always step down. Because in the beginning, if it's not a patient that you know well, it's a new patient on board in your practice, you do not know the risks. You do not know the personality. Which pathway are you going to follow? And I always say the young and the old and in between. The young, the small airways, you have to think for that disease progression. Are they a transient wheezer? Is it an asthmatic? How long are they going to be using this medication? Look at the other atopic diseases. The older patients, forgetful in what they are going to be using. So what schedule am I going to choose there? The businessman, the young or the middle-aged successful business person that is traveling all the time, living in George now. Also, we have got these patients that are following the summer. So half year they in the northern hemisphere, and the rest of the time they in South Africa. So the pollen exposure are always high. What are we going to do there? The lifestyle of the patient, and what is that specific patient's trigger? This was a survey that was done in Italy and in mild asthmatic patients, but 72% of them admit that they've got poor quality of life. But they're not using the medication all the time, because they are also the group that says that if they feel well, they don't consult with the doctor. And 22% of them actually had severe symptoms. Quarter of them had an exacerbation in the previous year, so it's now not mild asthma anymore. And 27% of them took oral steroids, and a quarter of those actually took it on a regular basis because they thought that would be okay, and that's a good way to treat our asthma on the long term. So that's not a good idea. So let's look at the molecules and let's see what what can we improve and can we learn so that we don't have these problems with our asthmatics, because we have to be optimistic in gaining control and compliance with the treatment plans. So the basket is short-acting beta agonist, your inhaled corticosteroid in combination with a long-acting beta agonist in the same device, montelukast. We have got in the same device adding a muscarinic agent to the ICS and LABA. Then we've got the biologicals. It is reserved for the more severe groups, but it is life-changing precision medicine. But we also have got precision medicine in allergy immunotherapy for house dust mite. And that's been the first disease-modifying drug that we had for many years. Yes, it is a Section 21 therapy, but it is available if we fill in the forms and we offer that to our patients that are allergic to house dust mite. And then oral steroids, but 10,000 question marks on should we even consider that as being in the basket for asthma treatment. So the 12 years and above, this is the new GINA Guidelines. You've seen this. We've got the two trials, the preferred track, where in step 1 and step 2, this is now anywhere between less than twice a month to nearly every day in a month. We have got as needed low dose ICS for formoterol. Okay, and then at step 3, where we have got daily symptoms now and some nighttime awakening, we have to use that ICS for formoterol every single day. So that can be still your controller and your reliever, but it is now cast in stone that it is everyday treatment, and then more than once or twice a day if needed, because I'm not really using a short-acting beta agonist inhaler on its own. And then above that. So if we look at track 2, at step 1, we use an inhaled corticosteroid whenever the SABA is taken. So that is all good. So if you have got your patient that is going to use your short-acting beta agonist and they're happy with their inhaler, but every time they are going to do that, you are now going to tell them that they have to puff on their inhaled corticosteroid as well. The minute that it is more than twice a month, we are going to do inhaled corticosteroid all the time. So remember now back to the schedule. The young and the old and the in-between. Choose carefully, because if you put the patient in this group, it makes life much easier often, because they are poor perceivers of their symptoms and they land up in trouble. A quarter of them still had acute exacerbations. So maybe we should remember that asthma is chronic inflammation and choose the right group to put them there. If they then are going to use the short-acting beta agonist, they are going to use the low-dose ICS again with that. And it's all good. Once we're at step 3, exactly as I said, your low-dose ICS for formoterol is now daily treatment. Your low-dose maintenance is still there, but you can now add your long-acting beta agonist in the same device. So they are going to use it all the time. And the anti-inflammatory is on board. This group is just going to still, because they are now cast in stone twice a day, they are going to use the inhaled corticosteroid. They are going to rescue with the short-acting beta agonist, because they still are on the inhaled corticosteroid. If they still use more short-acting beta agonist than what is preferred, then we are going to put them in the next group. We are going to add a leukotriene antagonist. We are going to add a muscarinic dilator as well, your LAMA, you can add in step 5, but you are going to go to a higher dose of the inhaled corticosteroid. But maybe there was a move from the one house to the next house, and there was painting, or there was a lot of mold in the house, but now that is all being fixed, you can step back to a low dose ICS. So remember, once you go to step 4, and it's now at a medium dose inhaled corticosteroid, don't leave them there if it is not necessary. The kidneys basket is even smaller. Just going back there, I'm not talking about the step 4 and 5s. We are focusing at step 1, 2, and 3. The kidneys basket is even smaller because there we don't have the LAMAs, your muscarinic agents. So it's and we don't have LABA in the beginning. So your short-acting beta agonist with your inhaled corticosteroid, montelukast, your combination with your long-acting beta agonist, allergy immunotherapy, the biologicals, and then oral steroids, even worse here if you consider the price. So this is in the children 5 to 11 years. Step 1 would be low-dose inhaled corticosteroid whenever a SABA is taken, or low-dose inhaled corticosteroid all the time. So we do not have the formoterol from step 1 on this case, and also not at step 2. So if we have got an adult that is a poor perceiver of symptoms, imagine a child, how do they perceive the treatment? So be very careful in leaving as needed treatment in the mom or the caregiver or the young child's discretion. So possibly a fixed dose of whatever you choose, but be careful for short-acting beta agonist overuse, because remember, if we think back to the slide that I showed, that part of risk stratification was what happened in that initial year of treatment of asthma, and too many dosages of your short-acting beta agonist and not enough inhaled corticosteroid. In the under 5s, it's even less. There we have got montelukast and we have got inhaled corticosteroids. So we have to be very careful. Again, in this group, obviously we are going to follow the lead of the pediatric allergist or pediatrician, because this is a difficult group to diagnose. We cannot do spirometry here. It's difficult, but we have to look at the littlies very, very well. Small airways, we don't want side effects. We don't want them to exacerbate and have numerous courses of oral steroids. I think there are not a lot of steroid phobia in our country. They revert back to all the trade names of systemic steroids very quickly, and that is their go-to drugs. And we have to be very careful in choosing a drug that is safe. Reevaluate every time. We check a blood pressure. We look at the hemoglobin A1C. We look at the cholesterol levels. We look at the TSH if we treat thyroidism. So we have to assess control. And if we cannot do peak flow or spirometry, then please use the questionnaires, the asthma control tests, and evaluate. Look at the history. Look at the dosage of rescue medication, and control the patient well. If they are uncontrolled, it doesn't imply that you just need to increase the inhaled corticosteroid dose. Before you do that, make sure it's the right diagnosis. Make sure you've treated the nose. Make sure they are compliant. Make sure they know the technique. A slow, deep, soft inhalation with a MDI, a quick maximum effort with a powder device. Spaces are underutilized, also in adult patients, also in your elderly patients, because they cannot use the inhalers well enough. maybe it is not enough medication. Maybe you need another group. Maybe you do need a higher dosage of the inhaled corticosteroid. Maybe the wrong molecule with the wrong size. This was not that recent, but Professor Osmani is just one of the most amazing researchers in asthma treatment also. The right inhaler, remember the elderly, missing teeth. It's difficult to use the MDI. Weakness, arthritis in their hands. Use a spacer in those patients. In a study that was done, 3,600 patients, insufficient effort for a powder device. Using an MDI with a spacer in these patients does make a difference. There are a huge population that does brilliant on a powder device, by all means. But if the patient's not controlled well, look at these things. A lot of them in this trial started breathing actuate the device before they are inhaling. And we want to inhale before you do that, because the plume has to go in with the breath. Otherwise, it's just at the back of the throat. So your breath actuating devices also overcome that problem. So good molecules with good devices are available, but we should get to the target. Remember the small airway disease that I've said. We are branching in our lungs 23 times, and it gets tough after 8. It gets small, and 89% of the inflammation of asthma is after 8, and those airways are really small. So if your molecules are too big in a child, in a patient that we are not controlling well, that we have got an inclination that this is a patient with small airway disease, don't be afraid of going to a small molecule, your extra fine particles, and your BDP formoterol combination and ciclesonide are the only two ultrafine molecules that we do have in our country. And the beauty of ciclesonide, I have to say this because it is unique and there is no other drug like that or molecule like that. It is a prodrug. It only gets activated once it's in the lung. The ripple effect in those patients that needs to treat atopic diseases elsewhere as well. The patients, obese patients that we do not want to have extra steroids on board, the steroid phobia patients, the patients that we need medium and high dosages of your inhaled corticosteroid because it doesn't get to target. The studies that has been done comparing ultrafine molecules to fine molecules, you need a lower dosage of the ultrafine molecule, and it just makes sense. Small airway disease needs small molecules. So let's treat our asthmatics well so that we can keep them up and running, out of bed. And how do we do that and get a better life? We explain and we involve the patient. And then we implement that plan. And then we reassess. And we explain and we involve the patient in the new plan. And we implement that and we reassess. And we do this over and over until we get a well-controlled asthmatics. And then we reassess next time, because they might have moved from Boksburg to George, and they might have lost their control or the inhaler on the way, moving 1,000 Ks. Life happens. Look at the schedule and the molecule, and let's treat our patients well. Thank you.
Thank you. Thank you so much, Corley, for that informative chat on asthma. Sure, there's always, I think it's one of the first diseases we learn about in medical school. And yeah, we just keep on learning. Yes, I see Dr. Cato wants to know if recordings will be sent. Yes, as always, it will be on the EMC website. I'm just going to go through some of the questions. I'll just go from the bottom up. Dr. Ria wants to know, she see that Gina mentions that there's a preferred LABA for Motorol. Is this purely because of the quick onset of action of formoterol and the fact that it can be used in the acute setting? How much of a difference does it really make? And should we be switching those that are on who are on a salmeterol combined inhaler to a formoterol inhaler?
No, it's actually not the preferred. Gina never implied that that is the preferred LABA. It's the preferred track. It's the only LABA that we can use in the first track. So that's why the guideline says ICS formoterol, because if you want to use ICS LABA as your controller and your reliever, it has to be formoterol. We cannot use salmeterol or vilanterol or any of the other LABAs to rescue with. Formoterol is the only one that we can use in that way, where we only use one device as the controller and the reliever. So once we are using our ICS LABA every single day, and then you're going to rescue with your SABA, that salmeterol, there's no problem. We know salmeterol is efficacious, but we must just remind our patients that there's no sense in puffing away on an inhaler that contains a salmeterol, because there's no dose response, and that's not going to help them.
Thank you. Thank you. That's very clear. Dr. Howard wants to know, is there any difference in managing an acute exacerbation in an obese asthmatic compared to asthmatic with normal BMI?
No, there isn't. The guidelines on treatment of acute exacerbation would still be everything that we have got on that guidelines, which is a talk on its own, so I'm not going to go into detail. So you are going to use steroids, even though we know that they are often less responsive, and we are going to use higher dosages. Now I'm sitting with that acute exacerbation, and I'm going to support that patient with oxygen, with treatment, and we are going to probably have a longer hospitalization with those patients, because it might take longer. But that would just inspire us to actually control the patient better and look at the treatable traits, also technique, so that we can, and the molecules that we are using, so that there is not another and another exacerbation.
Okay. Then Dr. Mulechi wants to know if this is just a problem in Mitchell's Plain or across the country with asthmatics just buying short courses of oral corticosteroids.
Oh no, that trial you saw was from Italy. It's not unique to South Africa. Overusing of short-acting beta agonists, which they can buy over the counter, and just going for oral steroids because they know that saves their lives. And we as doctors must also be careful, because if we dish out systemic steroids too easily to help our patients for various things, they get used to not being afraid of that. So they just go there because it helped, and then I don't need to use my inhaler. So unfortunately, education, compliance, huge issues worldwide.
Thank you. Thank you. And then Dr. Fersen wants to know, at what age or weight do you switch from the Symbicort 84.5 to 164.5? And how much, and I think maybe he's asking if you can just explain that SMART regime, how much inhalations are okay when they are having an acute exacerbation?
Okay, so that would be with formoterol and ICS formoterol. Yes. So yeah, that's also very difficult, and you have to individualize. So there's hard rules and guidelines, which it's difficult to explain in 2 seconds, because I'm going to say something and I'm going to be quoted later. So you have to treat the patient in front of you with whatever it needs to gain control. So if that patient is in trouble and they use 8 puffs of or 10 puffs of ICS formoterol on that day, they got the ICS in as well, as long as that's not going to happen again and again and again. So we need to use those exacerbations on warning signs and not giving them permission that it's okay, because every time that you have got an exacerbation, you just use it 6 times or 4 times or whatever number you are going to link to that. So that's why I'm saying it is very difficult to do that, because the age, you can have a small 8-year-old and a huge 8-year-old. You can have a small 10-year-old. So weight and comorbidities are going to play a tremendous role on what dosage you are going to choose.
Thank you, Carly. And then just a Pulmicort neb, is that in a sort of nebulized corticosteroid? Is that just for croup, or is it ever of use in an asthmatic?
We really don't promote using nebulized corticosteroids as a treatment option for asthma because of the lung deposition. If you think of the molecule size and how much of that dosage actually get to that 89% of distal airways, it's wonderful treatment for croup. So we do nebulize in hospital with oxygen and corticosteroids, but that is a different scenario. So in an emergency situation, by all means, but not by all means, still get better lung deposition if you use an ICS and a spacer. But if a nebulizer is all you've got, use it in acute situation, but not as a daily treatment for asthma, no. Also not for the children, because even in the kiddies or the little ones, you're nebulizing the room more than what you are nebulizing the child's lungs.
Okay, thank you. And then, oops, sorry, I lost that one. Tabisa wants to know, aggressive changing environmental triggers within the household. How much does that have to be emphasized? And I think we've just seen people in care. I think it got published in the UK and in the US about this toxic mold. And this is people in care, young people who end up dying because of asthma, because the houses can't get rid of the toxic mold. So how much should we investigate what's going on in the home and focus on that?
Absolutely. It's part of the treatable traits. And with my allergy hat on, obviously, you have to think about that. And even more so if you are near the coast. With the humidity, it definitely, there's no sense. I've always said that there's no sense if I up the dosage of the insulin and I do not tell my diabetic that he has to stop drinking 2 liters of Coke per day. I'm never going to win that battle, and we are going to have complications. If we do not get rid of the mold and we're just upping the asthma medication, but they are drinking the Coke in their lungs all the time, it's not going to win.
Madam Chair, Dr. Mulaji here. Can you hear me? Hello?
I can hear you. It's Dr. Lodder.
Hello?
Oh, you can go ahead, Dr. Mullah.
Yeah, I see you ignoring my questions.
No, I was coming to it. Which biologics are useful in asthma?
No, just one second. Regarding the use of steroids, like Smarties by our patients are getting them over the counter from your friendly pharmacist without a prescription. It is a very serious problem, and many of us are tending to ignore it. I don't think we can solve it, but it is shockingly being used by patients. That's just a statement. I don't expect our presenter to be a policeman. Yeah. Now the second
No,
question.
I did. Yeah,
I did all agree.
Yeah.
No, I did ask Dr. Mulaji.
Yeah, this has to be addressed at pharmacy level. It's a serious problem. The other problem I have is you say that your non-allergic adult onset asthma is less responsive to steroids, use biologicals. Now my note there is biologicals are ridiculously expensive. The one that I know of is omalizumab, which costs 5,600 Rand per 1.2 dose. So how do we go about, is there a cheaper version of the trade name is Xolair? How do you use it a lot? What is your experience with this?
No, yeah, it's your adult onset and your obese patients are less responsive. It doesn't mean that they are not responsive at all. And we do have other options as well. Your omalizumab is anti-IgE. So you again going to need that in an atopic asthmatic because the IgE level needs to be elevated. So it is expensive. It is one of the biologicals. It's the most cost-effective biological that we have. The others are even more expensive. So that's why I'm saying with precision medicine in this group, it is ridiculously expensive. And we are not accessing that in our country at all. But it hopefully in future, there will be other options. But that is also the patients that you are not going to go immediately to a very high dosage of just ICS on its own. You are going to do ICS LABA quicker and ICS LABA LAMA combination and even adding montelukast to those patients' regimes.
Thank you.
Thank you. Thank you, Dr. Mulaji. Thanks, Corley. And then just if you can say something about montelukast, where should we fit it in as primary practitioners?
So as primary practitioners in asthma treatment, it is obviously registered from 6 months of age. Those little ones, again, as I said, it's difficult to diagnose asthma with surety in those patients, especially if they're not atopic. So ideally, we should follow the guide of the pediatricians. But in real life, some of those patients never get to the pediatrician, and we have to treat with what is safe, and it has got safety data. I do have to just mention that looking after montelukast well is important for it not to degrade in the powdered form and also in the chewies, because it is secroscopic. It has to be protected, and those patients do well on the children with viral-induced asthma and wheezing. They do well. Short-term doesn't make a difference. So we have to use it long-term. Once they do have the psychiatric side effect of nighttime terrors, I haven't seen it much in my practice, but if they do, it's an idiosyncrasy. Don't go there again. That patient cannot have it, but it is a small percentage of the patients. In the other patients, your obese patients, your smokers, your patients with aspirin sensitivity, your patients that you can see that are compliant, they are using their medication regularly, but they are not responding well. Don't just up the dosage of the steroid. Add montelukast, just as we would do with a ACE inhibitor, with a diuretic, with a calcium channel blocker. We put all three in one. Use the basket a little bit broader so that we can treat more of the cytokines that plays a role in that inflammation, and don't give up too quickly. This responders and non-responders thing, it works in steroids also. As I said, there are some of these phenotypes that does not respond that well on steroids. So give it at least 6 months. That's my cutoff. 3 months, maybe, but 6 months before you decide it's not working.
Okay, thank you very much. That's very helpful, practical advice. And theophylline orally, does it still have a role?
It doesn't really have a role in international guidelines, but again, we are a resource scarce country and it is a bronchodilator. You have to be very careful for the toxicity. Don't use it in children because the therapeutic window is just too small. And also, if you do have a patient on theophylline, because it's just all you have got, to have some kind of treatment chronicity there. Be careful and just advise them to don't then add a lot of cough syrups that also contains theophylline and pushing them into theophylline toxicity.
Thank you. Thank you so much. I think I've gone through all the questions, yes, and the comments. Thank you very much, Corley. And thank you to Cipla. And I think, the consensus on the chat is just thanks for an excellent talk. And we hope to have you again on our